Hello, my name is Dr. Justin Hughes and welcome to the Sport Doctor webinar. I'm delighted today to speak with Professor Sanjay Sharma. He's a world leader in sports cardiology and is the Professor of Inherited Cardiac Diseases and Sports Cardiology at St George's Hospital in London. He's also consultant cardiologist for Cardiac Risk in the Young, a charity that promotes awareness of sudden arrhythmic death syndrome. Professor Sharma is the medical director of the Virgin London Marathon. He's also cardiologist to the Lawn Tennis Association, British Rugby Union and League, English Institute of Sport and the Football Association. I'm very grateful to Professor Sharma speaking to me today. We've converted today's discussion into both a podcast and a webinar. This is obviously in the webinar format. If you prefer to listen, then look up the Sport Doctor podcast, which is episode 5. So these are the subject areas that we're discussing today. The webinar is aimed at anybody working or interested in sport. I do hope you enjoy it. Please like if you do and subscribe to my channel. You mentioned about the sudden deaths or cardiacs in the younger population. What sort of proportion of cardiac deaths are made up in that group? So the sort of under 35 groups.
Well, we see about 30,000 cardiac arrests in the UK each year. And the vast majority of those arrests occur in people aged 60 years old or more. But there are young sudden cardiac deaths. And, I can't give you a figure on the actual young sudden cardiac arrest rate, but I can tell you that there are around 12 young sudden cardiac deaths in people aged under 35 each year in England and Wales. And that constitutes about 600 odd per year. That's a conservative estimate.
Yeah, well. And one of the things we did this podcast is because of the events of a couple of weeks ago. We saw Christian Eriksen collapse on the pitch, and that and from that it was deduced he'd had a cardiac arrest. Now, it was a very good outcome, and one of the things that enabled that was a very rapid response from the medical team and a defibrillator. What is a defibrillator?
A defibrillator is a device that has the capacity to deliver a shock externally and put the heart into a normal rhythm. So when someone has a cardiac arrest, that cardiac arrest can be due to a cardiac rhythm called ventricular fibrillation. And in this situation, the heart's not actually mechanically beating, but it's quivering at a rate of about 600 beats per minute. So you can imagine if you've got a pump that's quivering at 600 beats per minute, it's not actually mechanically doing anything to push blood forward. And most people with this rhythm degenerate into the heart just stopping completely. So if you don't get the heart started, it will invariably stop. And the only way to restart it is to deliver a shock from outside to the heart to stabilize the electrical rhythm. So what these defibrillators are, they are relatively small devices with leads and 2 pads which can be attached to the chest wall. You press a few buttons. They're quite foolproof because the general population is not supposed to be able to recognize what ventricular fibrillation is. But you've got someone guiding you through the whole thing, telling you what to press, telling you to move away when it delivers the shock. And they're very, very effective.
And we also saw the chest compressions, and I think that's what really upset a lot of people and made people realize very quickly it's a serious situation. What's happening with the chest compressions? Why do we do that?
Well, at the time that the heart's in cardiac arrest, it's not moving the blood forward at all. And clearly the job of the heart is to make sure that all the organs in the body are receiving oxygen at the very least, especially the brain, because the brain cannot do without oxygen for long. And clearly, if the brain's been deprived of oxygen for too long, then the outcome is really bad, because even if the patient survives, if the brain has had severe injury, then it's not easy to sustain life in that situation. So the aim of these compressions is to keep the blood moving, particularly to keep oxygen going to important organs such as the brain and the kidneys.
And one of the key parts of what we do in medicine is to try and prevent a disease or prevent an event happening actually before it does. Now we call that screening. And recently we've heard a lot about cardiac screening, and you're very prominent in the lead consultants of cardiac risk in the young. Tell me a little bit about that. What does CRY do, Cardiac Risk in the Young?
CRY are a charity, and their goal is to really prevent young sudden cardiac death. And this charity has been around since 1996. It started its focus on sports people because it was sport-related sudden deaths that were actually making the media. But it soon became very obvious to us that the vast majority of deaths in our population occur in non-sports people or in grassroots sport rather than elite sport. So they've set up a screening program that basically tests anyone aged between 14 and 35 for cardiac disease. Now, in real life, certainly according to our regulations, you can only be tested on the NHS at that age if you've got symptoms suggestive of cardiac disease or a family history. So a lot of people are not eligible for testing, but most deaths that occur during sport or in people that that are in the community occur in the absence of any warning symptoms at all. So what CRY offers is it offers screening to all comers aged 14 to 35 with a health questionnaire that pertains to symptoms of cardiac disease or a family history, and a 12-lead ECG, which is a simple electrical tracing that not just identifies electrical abnormalities of the heart, but can also sometimes raise suspicion of structural abnormalities. Now, if someone's got an abnormality on the ECG or on the health questionnaire, the charity will also conduct an echocardiogram, that is a cardiac ultrasound, at the same sitting. So they either end up clearing the individual, saying that there's nothing wrong with you, or if there's still concerns about something, then they refer that individual on to a specialist centre, such as the one at St George's Hospital.
Will screening pick everything up?
Well, I can only tell you from the CRY screening program. Let me just give you some ideas to what it does pick up and then tell you what it doesn't pick up. But the CRY screening program has tested over 200,000 young people. And we've shown that in that time, 1 in 300 young people have a cardiac condition that could potentially kill them. So screening will pick up electrical and structural abnormalities, and the sort of structural abnormalities are ones that I've alluded to some extent, a condition called hypertrophic cardiomyopathy or other cardiomyopathies, which are specifically heart muscle diseases. That screening will also pick up electrical faults that are either genetic or something that is congenital, that is something that someone's born with. But there are certain things that screening will not pick up, especially simple screening, because cardiac deaths are due to a diverse spectrum of diseases, not just from 1 or 2 sets. So these diseases cannot always be picked up by resting tests. So sometimes people need an exercise stress test, or even a cardiovascular magnetic resonance imaging scan, or even a CT coronary angiogram. Clearly, if we had to do all of these tests in a young person, then screening becomes very ineffective when we speak in financial terms, because sudden death in young people is relatively uncommon. So based on the test that we perform, that is the ECG and the echocardiogram, current screening would miss coronary artery disease because it's a rare cause of sudden death in young people. It would miss anomalous coronary artery origins. It may even miss incomplete expressions of cardiomyopathies or certain electrical faults, or even electrical faults that are only shown up by adrenergic surgeries such as an exercise stress test. I should also emphasize at this point that some people die despite screening, and that's not because screening missed something, but it's something that they may have acquired after they got screened. For example, a viral illness may cause myocarditis, or they may have played a sport with a severe diarrheal illness, and they may have had electrolyte abnormalities at the time they went in. They may have taken excess supplements, such as excess caffeine supplements, that may have triggered an arrhythmia. So all of these things have to be factored in.
And that leads on very nicely to the next question is, having spoken to some different CMOs, chief medical officers of sport, it's apparent that there's different approaches to this in terms of the frequency of screening. So some will start with an echo and an ECG when they enter the programs in their teenage years, and then around 2021 that might just become every 2 years or every 5 years. We always debate how often, how much with many medical screening programs. Do you think there's an optimum for sports cardiology, and why is the variability amongst some of the professional sports?
Well, let me answer the last question first in why sporting disciplines vary in their approach. And I think a lot of this does come down to finances. Some sporting organizations have more finances than others. For example, our Football Association is able to perform ECG and echo in every single player affiliated with the English Football Association, whereas there are other sporting organizations that aren't as well financially endowed. And those sort of screening programs do something as cost effective as possible. And they've confined their screening to just a health questionnaire and an ECG with view to performing further tests if the first two tests come back abnormal. In general, I think the ECG, which is the cheapest test, is probably the most cost-effective method for screening because it is abnormal in a very large proportion of people who have cardiomyopathies and will show up many of the electrical faults. So pound for pound is probably the best test that we can do, and it's got the greatest diagnostic yield of all tests. In fact, I can tell you that when we looked at our FA screening program that had tested over 11,000 people, where 1 in about 280 young people had a cardiac condition that could cause a sudden cardiac death, we found that the ECG picked up over 80% of all of those conditions, compared with only 25% for an echocardiogram. So that's the cheapest test. So that's what I would say that's the least we should be doing. But clearly, the more we do, the better the sensitivity of the screening program. Now, the second point really is how often should we screen? If we go back to that paper I was talking about, that the English football screening program showed that in this 10-year follow-up, we did have 8 deaths. We saved, lots of people lived that were screened and identified, but we did have 8 deaths despite screening these people. And these people had normal screens. 6 of these people had normal screens. So 6 people died despite normal screens. And the question is why? Well, the post-mortem in these people showed that they all had cardiomyopathy. So the big question is it that our screening program missed the cardiomyopathy, or is it that something developed afterwards? And we found that these people died around 10 years after they'd been screened. And what this tells us really, and this is the message I want to get across, is that cardiomyopathies don't always show themselves at the ages of 14, 15, or 16. They may not develop until the 20s or even the early 30s. And it's for this reason that a single screening test at the age of 16 probably isn't good enough if we're looking specifically for people who may develop cardiomyopathy. And hence the Football Association has certainly changed their stance to not just a single 16-year-old screen, but also a repeat screen at the age of 18, and then maybe at 20, and then maybe even 5 yearly, depending on the club that the player is playing for.
Moving on to the other question, you mentioned about electrolytes or caffeine or different changes that may have suddenly altered the physiology or the situation prior to an event. Are there any warning signs for this that may show in athletes, or is this suddenly completely out of the blue?
It appears that these deaths do occur out of the blue. I mean, obviously, most of the time when someone hasn't actually survived a sudden cardiac arrest, it's very hard to get any history as to whether that individual was experiencing any symptoms on the day that they died. But generally speaking, if you speak to relatives and friends and first-degree relatives about whether that individual had ever complained of any cardiac problems, the answer is usually no. Yeah. So, if someone's walking around with a very low potassium, the first thing that may happen is that they may feel slightly lethargic and weak, but they may not experience any cardiac symptoms until they get the cardiac arrest. Or you might find that someone's getting the odd ectopic, which they're not taking much notice of, and then they go into ventricular fibrillation. So the advice that we normally have for sports people or anyone that's exercising, there needn't be an elite sports person, is basically not to exercise if you've got a diarrheal illness, if you've got a febrile illness, you've got a high temperature, or if you've got coryzal symptoms that go below the throat. So if you've got something that's giving you a cold, that's giving you more than just if you've got a cold that's giving you more than a sore throat, i.e. affecting your chest and giving you a cough, then maybe you shouldn't exercise at that time. We always advise athletes to steer well clear, or in fact, all young people still steer well clear of illicit agents or amphetamine-based agents, which can all cause cardiac arrest. Now, the question about caffeine supplements is an interesting one, because clearly a lot of sports people and a lot of young people drink teas and coffees and espressos and so forth. I don't think there's any harm done by, one or two coffees before a game. But the effect of, very high doses of caffeine gels still needs to be explored in sport, the detrimental effect at least.
You mentioned about the sort of chest infection or the coughs and colds. Physiologically, what effect does that have on the heart? Why would that affect the increased risk of developing an arrhythmia or cardiac arrest?
Well, there are two things that concern us. First is that a high temperature can provoke arrhythmias in people with concealed electrical faults. So most people with these electrical faults may not run into any trouble at all until they have a febrile episode. One condition is Brugada syndrome, for example. This is a sodium ion channel fault that has the propensity of causing fatal arrhythmias and sudden cardiac death. But these deaths may not occur unless someone's got a very high temperature. So that's the one reason why we ask people not to train when they've got a high temperature. Secondly, of course, when someone's got a viremia, that viremia may dominate with a fever, aches, pains, and a sniffly nose. But that viremia may also have caused a subclinical myocarditis that the athlete may not be aware of. And so if someone's got a fever or symptoms that are going below the neck, then we usually advise them not to exercise or train until everything's been cured. So the first is febrile episodes can trigger arrhythmias in some predisposed individuals. The second is that a viral illness may cause subclinical myocarditis, and it's for that reason we advise people not to train in these situations.
Thank you for explaining that. There was shared relief for Christian Eriksen, but understandably questions that will always be asked in the sporting press about what effect this will have on his career. Now, I'm not going to specifically talk about Eriksen because we don't know the full circumstances, and it's unfair to do so on the athlete. But generically speaking, if an athlete collapsed and had a cardiac arrest, what does that do in terms of their career or just the general advice about returning back to elite and high levels of intense sport?
Well, the first thing to consider really is that what actually happened that day to any athlete who's had a cardiac arrest. The fact that the heart went into a very fatal rhythm that they survived suggests that whatever they had was terrible. The question then is, have we managed to treat that underlying condition? Or have we actually been able to find the condition that caused it? So the first point after someone survived a sudden cardiac arrest is to look for underlying causes that may be reversible. For example, a tight stenosis in a coronary artery that can be opened up with a stent, and so that individual's well revascularized. The second could be if they've got a congenital electrical accessory pathway that can be ablated. But all too often, we either don't identify an obvious cause or we identify something that's irreversible, such as a cardiomyopathy or myocardial scar. And in these situations, clearly there's a permanent substrate there for another potential arrest in the future. And so the third aim then, of course, is to protect that person from another cardiac arrest. And the way to do that is to implant a Cardiovertor defibrillator. And that device, of course, is a very small device that is implanted using a local anesthetic. The procedure lasts between 40 to 60 minutes. We basically place the device, which is a tiny thing about the size of a Ronson lighter, just under the collarbone, and it is attached to a lead that can be placed in the vicinity of the heart that watches the heart day and night and delivers the shock. And the question really then, of course, is what happens to the athlete afterwards in terms of their career? And that becomes very important clearly for a professional athlete who makes a living out of sport. And in that situation, we've got to take into account several factors. The first, of course, is the disease process itself. Is the disease process permanent? more importantly, is the disease going to become even worse with ongoing intensive exercise, such as arrhythmogenic cardiomyopathy, which is known to be exacerbated by sport? The second point is, what are the athlete's aspirations? Because clearly shared decision-making is very important. We've got to take all of this into account. The third thing, of course, is the legislation in any given country, because all countries have different aspects. Now, I just need to get across one important point about athletes exercising with defibrillators and why this is even being touted. Well, there is a multinational registry that is around that has collected data on over 400 people that have had defibrillators in situ and have carried on exercising or competing after implantation of these devices. These individuals have been followed up for 4 years, and in that 4-year period, there have been no adverse cardiac events. No one has died, although there have been some appropriate shocks. And it's based on this data that people feel that instead of just saying to an athlete, you will never play again, it's important to think about what the condition is, how effective a defibrillator is, and then involve the athlete in the decision-making process. Clearly, if the disease process is something that is going to get worse and worse with time, and we're dealing with a young individual who's got another 7 decades of life in him or her, then we clearly have to be a little bit more conservative about the approach that we take. But if it's a disorder that maybe, can be shocked, we've got to be honest with the athlete that the defibrillator is effective, but we don't really know how effective defibrillators are in scenarios where someone has been sweating for 90 minutes, is dehydrated and has got all sorts of electrolyte imbalances. Would the defibrillator work as well in that situation versus someone who's collapsed outside on the streets who hadn't been exercising? So all of these things have to come into consideration, but athlete autonomy has to be respected. And we've got to make sure really that the athlete is as safe as possible.
Absolutely. What investigations would you look at doing, and what sort of timescale are you looking at in terms of making decisions about return to play?
Well, obviously, someone's had a sudden cardiac arrest. That's a medical emergency. So, this patient gets transferred to hospital, and they will not leave the hospital until we have got a good idea as to what the underlying cause was. Or if we don't find that out, they have been protected with a defibrillator. So these tests take place very, very quickly. Clearly, once someone's admitted, the first thing on anyone's mind is what's the commonest cause of sudden cardiac death in the general population? And that's usually a coronary stenosis or a myocardial infarction. So the important thing really is to do a coronary angiogram and revascularize that person if you possibly can, either with an angioplasty or, even more importantly, some people may even need a bypass operation if they're middle-aged or more. The second thing then, of course, is to look for electrical faults, look for scar in the heart by doing an MRI scan. Both of these tests will be done in the same sitting. And some people may even need electrophysiological studies as an inpatient, but they will definitely not leave the hospital without a defibrillator in that situation. So even if it took someone like Eriksen's case, you'll notice that he went into hospital on Saturday and he was home by Thursday, if I remember rightly.
Yeah.
So it gets done very quickly.
And parallels have been drawn between the Eriksen case and the 2012 situation with Fabrice Muamba. There seemed to be a big difference, and reading back through there, Fabrice Muamba was in ITU for a number of weeks afterwards. I know every case is different, but is there any obvious reason as to why the Eriksen responded very quickly, and Fabrice Muamba was a real struggle to get his heart started again, and he was very poorly for a number of weeks?
Yes, and that's a very, very good point that you make. They both got treated both got good treatment. We saw that. I know it was unfortunate that there were television scenes that we were all a party to during both arrests. But what we did see from these scenes is that CPR was commenced quickly in both cases. The presence of ventricular fibrillation was established and shocks were delivered. So both individuals got rapid treatment. The difference is that the latest cardiac arrest, the patient was in ventricular fibrillation for a very short period. The downtime was very small. By that, I mean the time between the cardiac arrest itself and return of spontaneous circulation. That is the time at which the doctors got the heart working again. In Fabrice Muamba's case, that downtime was much, much more protracted. I think it was over 1 hour. Yeah. They kept going. And obviously in that time, the longer the downtime, we were expecting the situation to be quite grave because, he had, but he clearly got very effective cardiopulmonary resuscitation, that the brain didn't quite get affected as badly, and nor did the kidneys. But clearly someone who's had a downtime of that long will not be breathing themselves afterwards. So they have to be intubated. They have to go onto a ventilator for quite a long time. It's not until they wake up properly that we can, start rehabilitating them. So, but the good news is that even Fabrice has made a fantastic recovery since then.
Prof, thank you very much. I think these athletes recover because of people like you and the teams around you and all of the work that you do for sport. You're literally the professor who looks after the beating heart of sport. And we're really very, very lucky to have you looking after us. And I'm really, really grateful for speaking to me today. Thank you so much.
Thanks, Justin. Thank you very much.